Welcome everyone to Orthopedic Essentials. Today we will be discussing about one of the most fundamental and important topic in terms of PG examinations and medical students, that is traction. Through this video we will be learning what is traction, what are the kinds of traction, what is skeletal traction, what is skin traction, how they are applied, what are the landmarks. Then after that we will discuss about the confusing terms like what is counter traction, what is fixed traction, what is sliding traction, and all this. So to start with, before learning what is traction, we should know what are the deformities. Now in any limb, if there is a fracture or inflammation, the controlling muscles around the limb goes into spasm. The stronger antagonistic muscle will overpower and there will be a deformity in direction of the dominant muscle group. As evident in this picture, this is a subtrochanteric fracture showing the proximal fragment is going in flexion and abduction due to iliopsoas and glutei, and the distal fragment is going into adduction due to adductors. So there will be shortening and external rotation and adduction of the distal fragment, whereas the proximal fragment will be in flexion and abduction. So with this, let's deep into the concept of traction. Now what is traction? Traction is a force that is applied to the injured limb to overcome the deforming forces. What are the aims of traction? The aims of tractions are to reduce fracture by restoring the length, alignment and rotation. To reduce dislocation, it also relieves pain as it acting against the muscle spasm, and it allows the limb to be rested in functional position. What are the ways we give traction? What are the types of traction? Now traction can either be non-invasive, that is skin traction, or invasive, that is skeletal traction. Now in skin traction, the traction force is applied over a large area of skin. The traction force acting along the skin to deep fascia and then ultimately to the bones. Therefore, the traction in skin traction is applied indirectly to the bones. There is a coning effect, that is the traction force is acting over the large area of the skin which is transmitted to the deep fascia and ultimately to the bones, forming a coning effect of pull, coning pull, coning pull. Alright, traction is always applied, skin traction is applied distal to the fracture site for effective traction. Now what are the ways by which we can give skin traction? So we have two options, that is one adhesive traction and one is non-adhesive traction. In adhesive traction we use adhesive tapes to apply the traction. In non-adhesive traction we use non-adhesive straps. The maximum weight which can be given through adhesive skin traction is 6.7 kg, whereas in case of non-adhesive traction is 4.5 kgs. How to apply a skin traction? Now to know how to apply a skin traction, one must know the landmark. The landmark is an imaginary line between the tip of greater trochanter and the tip of lateral malleolus. The lateral strap will be slightly posterior to this landmark and the medial strap will be slightly anterior to this imaginary line. So to encourage the medial rotation of the limb. Now why to encourage the medial rotation of the limb? Because there is a tendency of the limb to rotate externally, and if we not apply the straps, the medial straps and the lateral straps this way, then the limb will remain laterally rotated and there will be a risk of common peroneal nerve injury plus reduction will also be not attained. What are the complications of skin tractions? What are the contraindications of skin traction? Now, the contraindications are when the skin is not healthy, in case of if there is abrasion, if there is laceration, or in case if there is skin disease like dermatitis, then in those cases skin traction is not recommended. If the limb is not healthy, that is the patient is a known case of peripheral vascular disease, or there is a varicose ulcer, or it is a case of closed fracture of high velocity injury having the soft tissue injuries having the signs of impending compartment syndromes, or if there is blisters, then skin traction cannot be applied. If there is marked shortening, there is very much overriding of the fracture fragments, so skin traction will not be enough to reduce the fragments. So in these cases we will be needing skeletal traction. What are the complications of skin traction? Now, complications are if the patient might be allergic to the adhesive, there can be excoriation of the skin because of the slipping of the strappings. There will be pressure source over the malleoli if they are not padded well enough. There will be a common risk of common peroneal nerve palsy if the limb is kept externally rotated, or if the bandaging around the neck of the fibula is tight, constricting. So this was about skin traction. Now, what is skeletal traction? In skeletal traction, metal pin or wire is driven through the bone and traction force is applied directly through the skeleton. Alright, in skin traction, we were applying traction force through the large area of skin, but whereas in skeletal traction, we are applying the traction force directly through the skeleton. Now, in skeleton traction, we use some pins like Steinman pins in case of diaphyseal bones and cortical bones, whereas we use Dunham pin in osteoporotic or cancellous bones like calcaneum. We attach the Steinman pin or Dunham pin with a bowler stirrup through which we pass a cord which is ultimately used to attach a load. Alright, now Kirshner's wire. Kirshner's wire is used to apply skeletal traction in case of in metacarpal regions, in proximal olecranon skeletal traction, or in pediatric fractures. Now, some important landmarks are, now in case of proximal ulnar skeletal traction, the landmark is around 3 centimeter distal to the tip of olecranon, just deep to the subcutaneous border of the ulna, from medial to lateral. Now, to avoid ulnar nerve injury, always take stab in incision. Don't go directly through Kirshner's wire. In case of proximal femoral traction, direction is lateral to medial. Landmark is 1 inch distal to the tip of greater trochanter, midway between the anterior and posterior border of the greater trochanter, and the limb should be in neutral rotation. That is, the patella must be facing the roof, and the direction of the drill should be towards the opposite side anterior superior iliac spine. So direction should be towards the opposite anterior superior iliac spine. Limb should be internally rotated so that patella faces the roof, and landmark as discussed, and goes from lateral to medial. We use screw eye, which looks like this, or a cancellous screw can also be used. For distal femoral skeletal traction, the landmarks are one line passing along the anterior border of the head of the fibula, another line passing through the superior border of the superior pole of the patella. They meet the point, they meet the point where they meet in the lateral aspect corresponding to this point in the medial side is the landmark for distal femoral skeletal traction. Again, the line passing through the anterior border of the head of the fibula and superior border of the patella, superior pole of the patella, they meet laterally. Now the corresponding point in the medial side, is the point of insertion of distal femoral traction. So here we go from medial to lateral. Now distal femoral traction cannot be given beyond 2 weeks because this will lead to stiffness of knee joint. So in those cases where we need to prolong the skeletal traction beyond 2 weeks, we will convert the distal femoral skeletal traction into proximal tibial skeletal traction. The landmark for proximal tibial skeletal traction is 2 cm below and 2 cm behind the tibial tuberosity from lateral to medial. Always ensure while you apply the distal tibial skeletal traction, the limb is kept flexed at the knee joint so that the forces are not acting directly through the ligaments, because there will be a risk of ligamentous damage or stiffness. For distal tibial traction, we go from lateral to medial. The landmark is 5 cm proximal to the ankle joint line in between the anterior and posterior border of the tibia. Alright, for calcaneum, we go from medial to lateral. The landmark is 3 cm below and behind the tip of medial malleolus, or 2 cm from below and behind the tip of lateral malleolus. In calcaneum, we can go through either side, or lateral or medial, but in examination you will tell from medial to lateral because we have more control over the insert of the pin into the bone and less control over the exit of the bone, less control over the exit of the pin through the bone. So for that reason only we apply the calcaneum traction from medial to lateral to avoid injury to tibial nerve and posterior tibial artery. For metacarpals, the landmark is 1 inch distal to the head of the second metacarpal. Alright, the pin will go through the second metacarpal and third metacarpal, and it should be perpendicular to the long axis of the radius. What are the complications of skeletal traction? Complications of skeletal traction are infection of the bone, incorrect placement of the pins, which will create a risk of cut out of the pin through the bones. There will be inappropriate rotation, inappropriate application of the skin. If we apply too much weight in the skeletal traction, there will be distraction at the fracture side. There is always a risk of ligamentous damage. There is always a risk of epiphyseal damage. Epiphysis damage, therefore, leading to growth disturbance or deformities. There is risk of joint stiffness nearby in the joints which are near to the skeletal traction. If we not give a good cruciate stab incisions, then there will be unhealthy scars. So after the landmark of the skeletal traction is important, regular pin tract dressing is important, right? And then the weight, how much weight is applied in skeletal traction, up to 10% of the body weight. Maximum is up to 10% of the body weight. There is always a risk of ligamentous damage and stiffness. Now let's learn about what is counter traction and why is it needed. Now, if traction alone is applied, then there is a tendency that the whole body will tend to be pulled in the direction of the force Therefore, if you have applied any means of traction yesterday evening, when you come to the ward, you see that the patient has been dragged towards the leg end, and the load is just resting upon the ground. Therefore, the purpose of that traction is not served. Alright, the traction only is not enough to achieve the reduction or alignment or to correct a deformity. There must be a counter force acting for efficient traction. So we apply counter traction. So counter traction is a force applied simultaneously and acting in opposite direction to that of the traction force. It is applied simultaneously and in opposite direction to that of the traction force. Now, how can we apply counter traction? Now, we can apply counter traction by two means. In case of fixed traction, the counter traction is obtained by applying force acting against a fixed point in the body. The force is acting against a fixed point in the body. Alright. Whereas in sliding traction, the gravity is used to provide counter traction by tilting the end of the bed. That is, by elevating the leg end of the bed, we are utilizing the gravity to apply counter traction. As evident in this picture, the leg end of the bed has been elevated, so the body is being pulled towards the head end. The body is being pulled towards the head end. Therefore, it is pulling the body against this weight. Therefore, counter traction is applied. So in counter traction, we use gravity. In sliding counter traction, we use gravity. Gravity is used. Right? How much to elevate? This depends on how much traction you have given. If you have given 6 pounds of the 6 pound load for traction, then you have to increase the leg end of the bed by 6 inches. Because roughly for 1 inch of the elevation of the leg end of the bed, there will be a counter traction of around 1 pound. Alright, so for 6 pound of the counter traction, we will be needing a wooden board of around 6 inch. Alright, now in case of fixed traction, I need you to understand this. Now, while you are applying fixed traction through Thomas splint, you are pulling the injured limb, right? You are pulling the injured limb, that you are applying a traction force over on the injured limb, and simultaneously you are pushing the Thomas splint towards the root of the limb, so that it sits upon the ischial tuberosity, and while maintaining this force, you will be tying the cords to the end of the Thomas splint. So in this way, fixed traction is applied. Alright. So this was all about traction. We learned what is traction. We learned what is counter traction, what is fixed traction, and what is sliding traction. So to summarize, traction is a force that is applied against the deforming forces to attain restoration of length, alignment, and rotation, to correct deformity, to correct dislocation, to keep the limb rested in functional position, and to reduce the pain. Now, traction can be given by non-invasive way, that is skin traction, or invasive way, that is skeletal traction. In skin traction, we can give adhesive skin traction or non-adhesive skin traction. Adhesive skin traction in maximum weight that can be applied is 6.7 kg. In non-adhesive skin traction, maximum weight which can be applied is 4.5 kg. In skeletal traction, maximum weight that can be applied is up to the 10% of the body weight of that patient. Alright, in skeletal traction, the traction force is directly applied through the bone. Then counter traction. The counter traction is the force that is acting against the traction force in opposite direction. Now counter traction can be fixed or it can be sliding. When we apply counter traction through a fixed part in the body, then it is fixed traction, and when we use gravity to apply counter traction by elevating the leg end of the bed is sliding traction. One must not confuse, and I think this must be clear. Now for 1 pound of the counter traction, we need to elevate the bed by 1 inch. So this was all about traction and counter traction. In the upcoming video, we will be discussing about the pins like Sands pin, Dunham pin, Steinman